It is very much amazing to know that we can detect shock even before the hypotension sets in, and which is basically by bedside assessment tool known as shock index, which is heart rate of the patient divided by the systolic blood pressure of the patient, and which if greater than 0.9 depicts early shock even if the blood pressure is normal and necessitates prompt management of the patient. If a patient presents to you with the signs and symptoms of thrombosis, DIC, or venom-induced consumptive coagulopathy for 7 or more days, then D-dimers should not be used in the assessment of these patients because the sensitivity of D-dimers decreases with increased duration of time. And also, age-adjusted D-dimers should be used in patients who are greater than 50 years of age. Unintentional severe weight loss, which occurs in chronic heart failure patient known as cardiac cachexia, may be preventable or even reversible with exercise training. If a patient presents to you with acute severe hemorrhage and you do CBC of a patient, then this patient's HB might be falsely reassuring because in initial and early stages the cells and the plasma is proportionately lost, and only with time, only with hemodilution, the HB will become low. Thus, serial monitoring of the patient, serial clinical assessment of the patient, and serial labs of the patient and CBC of the patient will further guide you to the best possible management of this patient. Absence of specific signs and symptoms of a specific disease does not rule out this specific disease. For example, if you are suspecting a patient with meningoencephalitis and he has no neck stiffness, no Kernig, no Brodzinski, it does not necessarily rule out meningoencephalitis. And if the clinical suspicion is high, we need to treat this patient empirically with antibiotics and antivirals as soon as possible for best possible management of this patient and to reduce the morbidity and mortality of a patient.